This is Dr. Kevin Sutherland, and this is a presentation on acute pancreatitis. Today's presentation will cover the following topics: etiology, pathophysiology of acute pancreatitis, the clinical presentation, diagnosis, prognosis, and finally management. There are many causes of acute pancreatitis. However, the two most common causes in the Western world are alcohol abuse and gallstones. The most widely accepted hypothesis for the pathophysiology of acute pancreatitis is the colocalization theory. Colocalization theory states that following a triggering event, such as consumption of alcohol or pancreatic duct obstruction, lysosomal enzymes are colocalized with digestive enzyme zymogens inside the pancreatic acinar cells. The lysosomal enzymes then activate psenogen into trypsin. Trypsin then activates other zymogens, which initiates acinar cell injury. The primary symptoms of acute pancreatitis are epigastric pain, nausea, and vomiting. The severity of physical findings is dependent on the severity of the attack and may include anxiety, respiratory distress, tachycardia, hypotension, and ileus. Serum chemistries can help aid in the diagnosis of acute pancreatitis, particularly serum amylase and lipase. This slide depicts some of the critical facts regarding both amylase and lipase. The ultimate severity of an attack appears to be determined by events that occur within the first 24 to 48 hours. As a result, a number of prognostic schemes have been developed. Ranson's criteria is the most widely used. If a patient has 3 or less criteria, they will undoubtedly have a mild attack, while a patient with 7 to 8 criteria will have an extremely poor prognosis, with a mortality approaching 90%. As an alternative to using clinical criteria, Balthazar and colleagues developed a radiographic prognostic scale based on contrast-enhanced CT examination. The scoring scale is based on a combination of pancreatic injury and necrosis. A score of 0 to 1 portends an excellent prognosis, while a score of 7 to 10 portends a poor prognosis. There are several management principles to effectively treat patients with acute pancreatitis. Pain management with narcotics and aggressive fluid repletion is critical. In addition to both pain control and fluid management, nutritional support is necessary to decrease the morbidity and mortality. Many patients with pancreatitis are unable to eat for prolonged periods of time, so alternative routes of nutrition, such as TPN or enteral nutrition via nasogastric or nasojejunal tube, are required. Furthermore, NG tube decompression may be needed due to pancreatitis-induced ileus. There have been many studies on the use of prophylactic antibiotics. Current consensus is that there is no benefit for prophylactic antibiotics for patients with mild pancreatitis. However, for patients with severe pancreatitis, there is currently no consensus. Many experts argue for imipenem with antifungal coverage, while others protest that prophylactic antibiotics have little clinical benefit and only increase the risk of resistant organisms.